All right, for this final session of the day, I'm pleased to have three healthcare innovators here. And one of the reasons we wanted to hold this panel as sort of innovation in health is one of these sort of over talked about terms. And as we think about sort of what is innovation, what works, what doesn't work, we thought it'd be valuable to bring people who are actually practitioners of innovation, who have worked with lots and lots of companies that are trying to build businesses in this space and create value, as well as a health system representative who works with companies and helps build them into the care models and validate them and select these companies. And so and there's so many nuances and challenges that go along with that. But these fine folks here will help illuminate some of that for us, which hopefully can be instructive in your research that many of you look at sort of how we adopt new innovations and how those innovations are translated into value in different contexts. So first, let me introduce Jennifer Henkin. She's Chief of Staff with Startup Health. And I think most of you probably, if you don't know of Startup Health, I'm sure you've seen their logo. They're one of the most prolific accelerators, investors, supporters of health companies, I think in the world at this point, with they're in over 60 countries and have supported hundreds of innovations. It's a really fascinating model, but I'll let Jennifer provide some more details on that. And she's also a former Smith School alum and employee with our Dingman Center for Entrepreneurship and our alumni group. And then to her right, another Smith alum, Anuj Desai, and a good friend of mine. Anuj is Vice President of Market Development for the New York eHealth Collaborative, which manages health IT development activities for the state of New York. New York has had the benefit of getting a lot of money years and years ago through what was called HEAL grants, and sort of been able to put in place an infrastructure that's sort of more advanced than a lot of the health information exchanges in the country, and has also invested a lot of resources in supporting innovation and entrepreneurship. And one of Anuj's other roles is helping support and lead the New York Digital Health Accelerator, which provides, I believe it's about $300,000 per company, give or take, and partners them with health systems. Has a whole portfolio of companies, which he'll provide some insights from what he's learned from that process over the last several years. And to Anuj's right is Pete Solano. He's Director of Consumer Initiatives with MedStar Health. MedStar Health is one of the biggest health systems in this region and has been a leader in innovation. They've have a wide portfolio. I'll let Pete talk more about that, but his portfolio ranges from precision medicine to access via travel and other online and digital initiatives. And this is the last panel of the day, so we want to keep it fun. So we're going to have each of them give about 5 minutes, a review on sort of their perspective, sort of where their perspective comes from. I have some questions for them, but we also want the audience to be engaged. So I'll probably start with one question, then we'll open up to the audience, and depending how engaged this audience is, may have some additional questions. But if history is any marker, the white audience typically has lots of questions. So with that, let me ask Jennifer to talk a little bit about her role and insights. Thanks.
Let's see.
Can you see it? Yeah, I'm fine.
Okay. So thank you, Kenyon, for the introduction and for inviting me to be a part of this. Excited to participate in a University of Maryland event from the other side. I'm so used to being behind the scenes planning. So as Kenyon mentioned, I'll go into a little bit of Startup Health, but want to kind of just set a little bit of background kind of for why Startup Health was founded 5 years ago. So we're in this once-in-a-lifetime moment where there's 5 conditions that are aligned for the reimagination of healthcare. First one is that healthcare reform has created a lot of opportunity as business model shifts from fee-for-service to value-based care. Secondly, there is increase in chronic disease, aging population, and rising costs are increasing the demand for cost-efficient solutions. Third is the golden age of entrepreneurship. So it's never been easier, cheaper, or faster to become an entrepreneur in this space. The fourth is digital health, so the rise of mobile devices and access to technology. And then the last is globalization, which is breaking down innovation silos, really between startups and investors all around the world. So Startup Health is organizing and supporting what we call a global army of health transformers to improve the health and well-being of everyone in the world. So briefly, I just want to run through a little bit of what Startup Health is. So there's really 6 parts to our business. The first is this growing global army. So we have a portfolio of 167 companies from 16 countries and 70 cities around the world. The second is a lifetime coaching program. So unlike short-term incubator accelerators, we support companies at every stage of the business life cycle. So for the lifetime of their business versus just 3 or 6 months. The third is an active global network. So we have 30,000 investors, customers, and stakeholders, including programs in Finland and Colorado who are committed to supporting innovation in the healthcare space. Fourth is a media platform. We reach over 100,000 influencers every week via social media, newsletter, and we're able to tell the stories of our portfolio companies through there. We have a tech platform that is available to our portfolio companies, which is captures data and insights from the entrepreneurs on a daily basis about what's working and what's not working, which stakeholders are helpful and which aren't. And the idea is that together with that data, the entrepreneurs can build their businesses more effectively and more efficiently. And then the last piece is our team. So we have over 25 team members, mostly based in New York, but around the country who have a lot of experience both in healthcare as well as in building in building businesses. So and we're also supported by a number of different organizations, large brands, health systems, pharma companies, and you can this is just a limited group of them. And we have, as I mentioned earlier, the largest portfolio of digital health companies, 167 are in 16 countries. There's just, the logos there, really representing a wide spectrum of health innovation. And so just want to briefly, before I end it, talk a little bit. We publish what's called Startup Health Insights, which is quarterly reports on all the funding that has gone into the digital health space. So since 2010, when we started tracking funding, we have, over the past 6 years, $25 billion of funding into the digital health space. So this year to date, through Q3, has already exceeded the total funding from 2015. So we're expecting, obviously, that by the end of the year, that funding could be close to possibly around $8 million. You'll see that, we track also by subsectors. You can kind of see, whereas a couple years ago, big data and analytics was the big play, we're seeing more solutions around patient and consumer experience being funded by VCs, both traditional venture firms, but as well as corporate venture arms that are coming into investing in healthcare as well. And then just focused on the U.S., obviously there's big hubs like San Francisco, Boston, and New York, which have traditionally been, known headquarters for health companies, but there's also other areas, innovation hubs, kind of the rise of the rest, as Steve Case has kind of coined over the past couple years, that are popping up, places like Dallas, Chicago, Minneapolis, Washington, D.C. We recently launched a program out in Colorado. So it's not really just kind of the traditional East Coast, West Coast. It's really happening all across the country. And that's my opening. So thank you.
Cool. Well, thanks, Kenyon. Thanks, Jennifer. Thanks for having me. I often look back fondly on my time at Smith, and really got me into health IT, which has been so fun to do. I'll spend just really about 3 or 4 minutes here. Our New York Health Collaborative, we are a nonprofit. We're the state HIE in New York, so we really come at this from a very different angle of why we're interested in innovation. Through the Shiny, which is our statewide HIE, as Kenyon mentioned, we have received a lot of grant dollars, as well as a lot of state support to keep it sustainable. We have 40 million patient lives in our state network. We process about 3 million transactions a month. Almost 100% hospital adoption at this point, but a lot of other stakeholders need to still get adopted and use the HIE. But what we found 5 years ago is that, while physicians were going through adoption of electronic health records, they still, as we moved to this area of value-based care, they saw a gap in the marketplace in terms of the capabilities that the electronic health record vendors had and the needs that they had in the marketplace. So we found a need to create a program. And at the same time, by the way, there was also entrepreneurship happening in New York. New York is already a tech hub, really in many sectors, but could it also be in health tech? So 5 years ago, we created this program called the New York Digital Health Accelerator Program that was funded primarily through state funds as well as through corporate sponsorship dollars to help healthcare providers specifically shorten the sales cycles for tech companies to get into healthcare providers. And that's really what we focus on, is only customer acquisition. Our companies, it's a 5-month program. If they're solving the needs of healthcare providers, specifically around care coordination or patient engagement analytics, they belong in our program. We've run this program now, we're in our 4th class, I think now. We've had 21 companies graduate over the last 3 classes. We've launched 47 pilots. So we really try to get to helping them get to pilots and helping get to customers and then eventually growth. What makes our program unique is our healthcare providers. We have a group of about 23 large health systems that have come together that are interested in innovation, have said that we want to work in a collaboratory fashion with each other in terms of finding common tech solutions that work across the ecosystem. And so we have all the big names in New York and some of the small providers as well that are really committed to innovation and making New York a hub for health tech. In past years, we've also funded the companies. Kenny mentioned $300,000 typically we've done per company. But we found now people really aren't looking for money. They're looking for access, which is really where we're focusing. And this is just a sample of some of our companies. We have another 6 that are in now that aren't on the slide, but really focusing on patient engagement, care coordination, workflow improvement type analytics. But all these companies are selling to healthcare providers. Is that? Okay, great.
Hi, everybody, and thanks for having me. I don't have any slides, but I do have 4 big disruptive factors I'm seeing in healthcare. So MedStar, you may know, is 10 hospitals. We have Georgetown here in DC and 9 others, and we have 250 outpatient locations. You wouldn't describe yourself as just hospitals in the current era, right? And I work in the innovation group, which means I can work on anything, but I like to say as long as it drives incremental revenue. So I'm not a doc or a nurse, so you wouldn't mind see me talking too much about better outcomes. It's healthcare, we're supposed to do that. Costs is hard in healthcare because most of our costs are labor, and everybody lies about cost reductions, so it's not popular as a notion. But if you can drive incremental fill, as we did with ZocDoc and Uber, or profile tumors in a way that brings in new patients, as we've done with Caris, those are popular notions. Caris is like a Quest or a LabCorp for tumor profiling. Here's the 4 big changes I'm seeing, and one of these is a cliche, but maybe the other 3 will stand out. The first is disintermediation. Providers are trying to get rid of payers, and payers are trying to get rid of providers, right? So every model where there's an extra channel, when the web or mobile comes along, it tends to obliterate that extra channel. And we know there's a lot of inefficiency in healthcare because we have 2 separate entities, often not completely in sync, the provider and the payer. So I think you'll see with the rise of web, mobile, and everything else that players like MedStar increasingly will become a payer, and payers will not just stand idle as we do that. They'll increasingly become providers. More on that when you hear number 4. Number 2, Jennifer spoke to so well, platforms. So we can try things so fast now. We say fast fail, fast scale, because we can use just what we need, right? These cloud platforms, you buy what you use. So with ZocDoc, we put 30 docs on. It worked great. Now we have every doc on ZocDoc. We were one of the first, if not the first, healthcare system in the world to bolt it into our EMR bidirectionally. So that's a side point on platforms that you can tie them into the EMR. That was verboten years ago. We thought it was either not allowed or it would cost us money from Cerner, Epic et al. Neither of those things are true. Third is my favorite, no more Marcus of Queensberry rules. So that means healthcare used to be genteel. It was governed by certificates of need, right? Before, you'd stay out of their market if they stayed out of your market. And the CON process, which was talked about here today, made that a fact. But that's now like taxi cab medallions in New York City. We know what Uber did there. For outpatient offices, for getting to your home, there is no need for CON. Healthcare is consolidating rapidly. That means every day it's a bitter battle among the bigs in any given market for market share. And finally, and this relates to disintermediation, the hottest thing in healthcare is virtual visits. The notion of seeing not a doc for your sinusitis, but a nurse who will give you a script via two-way audio and two-way video. And that's the power tool that we're using to try to disintermediate payers, and they're going to use to try to disintermediate us. So if you ever want to see a Sentinel press release, actually two in about the same week, one of the big players in virtual visits is American Well. There's a bunch, Teladoc, MD Live. But pick on American Well for a minute. In 1 week, probably 6 months ago, they did a press release with I forget who, I'll say Bon Secours, announcing yet another healthcare system partner. And in that same week, they announced the Blues of the Mountain States. The Blues of the Mountain States, right? And the Blues of the Mountain States said, if you just have something mild like sinusitis, why do you need to schlep all the way to the provider? Just call us. Two-way audio, two-way video. So probably if you remember nothing else from my little speech here, remember disintermediation and virtual visits. That's worthy of your time and attention. And it's not going to unfold very fast. It's already started to unfold very fast. Thanks.
All right, thank you, Pete. So I'm going to ask one question and then open it up to the audience. So this audience is filled with health services researchers. So I would ask you, so what are your most sort of important and unanswered questions regarding sort of the adoption and use of innovation?
Sure. Unanswered questions. So I think, actually, I don't know how to answer it, but I'll try. I think one of the things we struggle with a lot is evidence. There's a lot of digital health companies out there, and actually a lot of them want to reduce readmissions, for example. So a lot of competing solutions that do pretty much the same thing. What we've seen a big shift in New York is trying to get to what actually works and what actually has evidence of works in systems. So we've worked, for example, with Mount Sinai Health System in terms of launching a program where they are actually trying to fast-track research of health IT systems or health IT solutions within provider systems through shortened pilots where they can prove there's value here before they go and acquire that broader system. So I'm not sure if it's there yet, and I think that's a big opportunity, and I think it's an opportunity for researchers to really think of what is the value of some of these technology solutions.
I think, I would say kind of two areas. One is how to take research and kind of bring it out of the silos. So I actually was at SAP event a couple days ago where the vice president spoke, who's leading the National Cancer Moonshot, and he discussed how they've now enacted legislation, or I don't know if it's legislation officially, where they can find health researchers who aren't disclosing their medical advances at the rate of $10,000 a day. So it's this idea of, how do you not keep the data in silos? We have two companies in startup health. One is Cohero Health, which was the founder was a PhD student at Mount Sinai, and the technology kind of spun out there is for respiratory care. And then another company in Germany that is called TuneHub, which is working with academic researchers to help commercialize their technology. So kind of how do you bring the research and the tech out of the university and kind of make it available to the broader population?
I feel like we're great now at collecting dots, and now we have to start connecting dots. So a good example is genetics. It's fascinating. Veritas Genomics raised, $30 million this week for a whole exome, whole genome at ever lower pricing. 23andMe obviously paved the path, but there's 4, 6, 8 others that will help us all get very close, I'm sure, to $100 or less, whereby we can get our whole exome or genome assayed. But where's the clinical actionability, right? So we have 20,000 genes, each of us, about 50, 60 actionable genes today. So I'd be very interested and excited if we can figure out genes 61 through N. It doesn't have to be 20,000, but I'd like to see thousands. And I think there's great hope for pharmacogenomics, right? Targeting medications, since we're such a pharma-heavy healthcare system here in America, at gene mutations, at protein alterations. So that's where I have great hope. But I feel funny talking about it at MedStar when there's 55 actionable genes. It doesn't seem like many.
Yeah, interesting. I agree. I think genomics is that next shift in healthcare over the next 10 years that are, have one of the most profound impacts.
Yeah.
Does the audience have any questions for this group? Yes.
Yeah, my question is about the government incentives for EMRs, the Meaningful Use Program. There are two views about it. One argument, which is provided by the government, is that these financial incentives helped to grow the number of people who are having EMRs. On the other hand, some people argue that the focus on EMRs pushed the other innovations out by diverting the focus on only a specific kind of technology. So my question is to all the members of the panel, do you think that meaningful use incentives helped you by creating the potential to build upon the EMRs, or hurt you by only focusing on EMRs and not on the solutions that you guys are talking about?
I can take a try at that. I think there was misdirection. I'll give you an object example. Is the MU incentives tried to encourage us to do a patient portal. Nobody wants a patient portal, right? The cliche was there would be a mint for healthcare. There were a lot of mints for healthcare. People don't want them. They just want a nearby, near-term appointment, which is why players like ZocDoc have flourished. So now I noticed that the MU incentives for a portal have been reduced to effectively zero. Like if you get one user, I think that's enough in year one. But in any case, we have to focus on what patients, really consumers, want, and not chase the money associated with those MU incentives. I think it's an artificial incentive. It caused us, most now are over it, but it caused us to chase rabbits we shouldn't have.
On the flip side, though, from an HIE perspective, because we are an HIE, now we have 10,000 physicians who didn't have EMRs before Meaningful Use program that are using electronic health records. Now, do they have issues? Absolutely. Interoperability is a major issue. I wish the government had put more strict standards in place, and so the vendors are not building their business model on interoperability, they're building it on the functions that actually they need. So I think it's a mixed bag, but did it meet its goals? Absolutely.
Rajiv?
This is for Pete. I really like the metaphor that you use of we connect the dots, but we can't connect the dots. I also feel that the exciting part is not so much on these devices that are collecting the data, but what do we do with that data?
Right.
So with that in mind, tell us what needs to happen for us to connect the dots, perhaps using an example at MedStar.
I know a great one in pharmacogenomics. It's AssureX Health, right? So we have so many patients now with behavioral health challenges. It's the single biggest entity in U.S. healthcare. And AssureX Health is a rare company that focused like a laser and addressed the dot connection problem. So for ADHD, depression, and anxiety, they proved that they could help the doc get to the right medication for a behaviorally health challenged patient far faster, with fewer side effects, and with a smaller copay for the patient, right? Really addressing the patient's financial imperatives. So I love that one. I noticed they just sold for a big sum of money to Myriad Genetics. And there's a number of bright spots like that. There's one right over your shoulder. I see Steve Davis there. We like M3 for screening. So again, in behavioral, we've long been hampered by the fact that the screening instrument is only so-so. It's the PHQ-9. It happens to be free. Came from Big Pharma, but it only looks at depression when we know there's depression, anxiety, PTSD, and bipolar. More so, you got to anchor that in primary care where most folks go, right? They don't get to go to a psychiatrist straight up. So Steve Davis and his team have come up with the M3, an evidence-based instrument that goes across all four and works so well in primary care. We're strong proponents of it. So when we find these companies that stay, like I said, laser focused on a need that's a prevalent entity for us, right? Not Lyme disease, but depression, anxiety et al. That's terrific.
Thank you.
Rita?
My question actually jumps up a point that was just made about financial incentives. And I guess my question for the panelists is, a lot of these innovations are targeted with consumers in mind as the ultimate users, but consumers are not going to pay for them unless it's something like ZocDoc, which is for free. So, what is the challenge that you experience in getting payers, or your company's experience in getting payers to pay for the stuff? Because right now they're the only ones with money.
I don't do that. This is a rare fork in the road that I took right. I never have teed up projects at MedStar looking for reimbursement, chasing those, ethereal CPT codes. It's always about driving incremental fill. So here's something very inside baseball for you. We're like a hotel. A slot on Dr. Steve's schedule that's empty today is revenue lost forever. It's actually worse because you don't get any downstream revenue either, right? So every 1% of fill, F-I-L-L, at MedStar is across our 2,000 employed docs is $10 million a year in revenue. So if ZocDoc and Uber, these are two good ones for us, drive 2, 3, 4% incremental fill, that's $30 million. When most of your costs are fixed, where does that go? So when I look at an M3, I look at the extent to which it drives us new patients or new appointments from existing patients. The rest just gets worked out, I figure.
And I would just add in briefly, at Startup Health with our portfolio companies, I think we're continuously having to work through the challenge of the end user is not the same as the primary paying customer. And so, how do you focus your time on selling to the person who's actually going to be paying for it, which is the payers in most cases, versus the user, which I don't have an answer to, but it's definitely something that, conversations we hear from entrepreneurs day in and day out.
I mean, for us in New York, pretty much all our companies are focused on value-based care type initiatives around care coordination or patient engagement, et cetera. But what we're trying to spend a lot of time with them is help them understand the Medicaid program, or DSRIP, which is a very big $7.5 billion program in New York over these, we're halfway through. So some of these, if they're able to prove a pilot in the first year or two of the program, they can actually be written in as a vendor as part of the Medicaid DSRIP program. So we're really trying to really put them squarely in the value-based care initiative around Medicaid. And we've seen some of our early companies now have contracts that are fairly big with these large provider organizations that are part of this Medicaid program.
Hi. Yeah. My name is Ravish. Basically, every time we speak about innovation, we generally would like to speak about the unicorns which are doing good in the industry. So, and sometimes, yes, we also like to speak about unicorns failing. So when a company like Pet.com fails, not a lot of people will be affected. But when a firm like Theranos fails, I mean, there are a lot of policymakers who will be interested to look at what's going on. So generally, when in a health innovation, if such events happen, how will this affect the innovation industry as a whole? How will a startup accelerator like a Startup Health or NYE Health Collaborative look into it? How will a provider like MedStar look into it when these kind of events happen?
I can take it on the team side, which I think is probably, there's a lot of issues with Theranos, but I think probably the built out founding team. So at Startup Health, when companies apply, we're looking more through the lens of who's the founding team versus what is a specific idea or business that they're applying with, because, things can change so quickly, they'll pivot, they'll change their business model. But, if the core of the team, if there's, not a solo co-founder, so obviously we've seen more success when there's multiple co-founders, somebody who has both the business experience as a CEO, somebody with the technology experience as a CTO, and then somebody with the medical experience as a CMO, kind of this built out founding team is going to have a stronger chance of not only receiving funding from investors, but also kind of being able to make it through the ups and downs that is, but not only entrepreneurship in general, but especially in healthcare. And I think that, probably, maybe possibly, some of their issues related to not having kind of a robust enough founding team from day one. So I think that definitely, the team and the team members having the right mindset of really being committed to building a business in this space will take years, is what's going to make those breakthrough.
Okay, I'd be interested in each of the panels talking about scale, particularly around the dilemma that we're talking a lot about innovation, which is the startup phase, but a lot of the scale happens in cooperation. And much of our discussion today has been about how do different parts of the system talk to each other, how do we get incentives for cooperation. When we talk about community health, we often talk about theories of change and secondary effects. So anyway, I'd be interested in comments about Are there examples of where there are incentives to cooperation, and are there examples of scale?
I can only say that if I find a company I really like and they can't grow organically, which is often the case, if they lack capital, I'll try to guide them to a venture fund where, my recommendation might be interesting, right? Because we're one of the early customers. So I'll give you an example of a player we did that with. A company, we were first with Uber. So I love pitches that are an Uber for blank, right? So a year ago, I got a pitch for an Uber for phlebotomy. Right away, that got my attention because 30% of people don't get their venipuncture. So they don't continue with us. They can't continue downstream. So these guys in Richmond, it's a company called Igbo, I-G-G-B-O. I really liked what they were doing, and I helped guide them to a VC fund that ended up putting $13 million in. Now, they were so kind of interesting and expanding rapidly and having great results with systems that they could have found the money maybe completely on their own. But with an intro from somebody like us, maybe it happened faster. And I needed them to be able to scale with us, not to mention across the country to get their own innovation factory kind of humming. So we've had the opposite of that plenty of times too, but that's a success story in that realm.
I really like your question about collaboration and scale. And I think that's one of the things we're trying to help our companies with. One company that comes to mind in our first class is a company called Curator. They were a really early stage company when they came in, and they focused on secure messaging, which I feel like there's maybe 50 companies that do secure messaging. But what they pivoted to is looking at alerts. And alerts, as for a provider system, is really critical, especially in New York City. 40% of your patients travel across provider systems. So when they show up in another emergency room, you need to know what happened so you can avoid some penalties. And they pivoted a little bit with that, and they also got a set of customers in a certain region all signed up. So if they were all using the Curator system and leveraging the HIE with us, they had access to data across the ecosystem, I would say. So we work a lot with companies trying to get them in with collaboration with partners. The district program, again, I mentioned, you have a lead hospital system. You might have 400 trading partners that are collaborating for care within that community. And we're really trying to get them on common platforms, common EHR systems, common HIE, common systems they're using, and that's really going to help our mission.
And on the startup health side, we have a handful of companies that probably, are similar with some tweaks. And so the thought is that there's going to be one or two that's going to really break out. So we right now probably have 5 nutrition companies that all have their own flavor, but, in the next coming months and years, there'll be probably 1 or 2. And so how do we kind of allow these companies to collaborate, maybe possibly, one is acquiring the other or the technology or the team. We've had that actually with Cake Health, which was is kind of a mint for healthcare, was acquired by one of a billing company that is in startup health out in Connecticut. And so we see that happening. It will probably happen a lot over the next couple years around consolidation, even within our own portfolio for the breakouts to kind of make it.
So I have a question here. I was really saddened by Pete's comments that no one likes patient portal. Because because the audience here, right? We're trying to prove that the patient portal brings value. Anyway, so my question to you as well to the panel is, what's your take on patient empowerment? Are there kind of innovative opportunities there? So,
well, you're going to think this is heresy, but I think it's overrated. Right, I'm being
the wonder drug,
serious.
damn it.
Yeah. The patients who can engage the most, all of you, we see the least, and the patients who can engage the least, we see the most. So, I would much rather figure out a way to remove the friction from access, allow you to book online 24/7, pay for your ride if you're an indigent patient to get to the doctor, but meanwhile, figure out how to knit virtual visits into every aspect of the ecosystem. So what that means is we got to have a kiosk, right? Because indigent folks don't have ready access like we all do to smartphones and tablets. So it might mean we have a retail strategy, right? Where we locate these kiosks, maybe they're DIY or maybe they're attended by an MA in retail locations. But I'm not a fan of patient engagement. Most of the patient engagement approaches have proved hollow. Remote patient monitoring for us has been a complete wipeout. It's the platitudinous trio of pulse ox scale, blood pressure, you put it in the patient's house, You ask Anuj to do those each day. Data flies through the cloud. You've heard the story. He'll do it for like 2 days. That's it. It's just not habitual. However, my wife, as an example, the other night did a virtual visit when she thought she had sinusitis. And she comes out of her study after 7 minutes with a script, and she goes, I'll never go to the doctor again. So the delight, you should try it, for a virtual visit, which is about $35 you have to pay for the most part, is so stratospheric that it makes us think we should run to that spot.
Yeah, good question. And I think, when we talk about what are the features that patients truly value that are useful for them, but also usable as an experience. And when you merge those two things together, you have a much greater chance of success. So if you're talking about a patient portal, all the things that aren't value producing, I think our researcher was talking about that earlier as they looked at the different component parts. If we can isolate which parts are most value producing and focus our energies on what is going to create the most impact and the most empowered patients, that might be something to think about. Well, it's 4 o'clock, or it's a few minutes after 4 o'clock now, so I'm going to go ahead and break the formal session for today. But we are going to move to a networking and research poster session. We have about, I think we have 10 really wonderful research posters from a variety of researchers across the country and some, I believe, from across the world. So that is going to be at the end of this hallway in the Scott boardroom. So get a snack and talk with those researchers, and our panelists here will be in that session as well if you want to talk with them.